Tanikum Vayanadi Vaipachayal. So the English translation, diagnose the disease first, then seek to find its cause, find means to relieve and cure the same, then put into action the appropriate steps involved in that. He has told it long back, and not only he. And of course, this is our friend. I know him for a long time. We have been in rational drug therapy as well as breastfeeding movement. And he is a very famous article, okay, in Indian Pediatrics. And I have taken his permission and he has given it. And see, he always mentioned rationale. Ration means you have to ration everything. No, we know when there is something in shortage, but we have abundance, but we have to ration the use of it. So ration, reasoning for prescription, right dose, route, and duration. Academically updated decisions. T, training of mind, residents, parents, pharmacists is very important, and also the company fellows. Okay, training of mind, residents, parents, pharmacists, and also all the government officials involved in healthcare. Instructions to parents, very, very important. That's why recently also I found some doctor has been assaulted. Organism search. So you have to find what is the cause, whether it's a virus, whether it's a protozoa like malaria, or it is some rickettsial fever, etc. Nothing down, noting down the diagnosis. Documentation is very, very important to avoid problems to everybody. So as soon as you think of writing a drug, you write the diagnosis and the probable diagnosis. Just in the morning, I was listening to Dr. Amdekar. He was telling, if you are not giving antibiotics, then mention there, because I am not sure about the diagnosis, because the child doesn't have any specific symptom. Wait for 1 more day, 24 hours later, you come and see me. That's what he was telling in the morning. Be frank and tell what is happening, and then tell we will follow up the child. Anytime you want to ask doubt, you ask me, then we will do the investigations. So everything has to be documented. Then antibiotic policy should be there for individual, personally, as well as for the institution where you are working or hospital where you are working. Then local sensitivity pattern and susceptibility should be known, and it must be updated frequently for various organisms and various currently available antibiotics as well as the previous antibiotics. And then finally, as he says, very important is ethical considerations. You must always follow the ethical principles of only giving antibiotic if you are very sure if it's going to be an infection. And economic condition of the patient is very important in finding out. You cannot give 8 rupees or 12 rupees for a laborer's child. Now become aware about antibiotic misuse. This is what is very important for this year. So do you know antibiotics, the chief weapon? You know this poster, safe use of antibiotics, responsibility of all of us. We have no doubt about it. And that's why you organized. And Kerala Pisharodi has, in Kollam conference, he had done a workshop, 1-day workshop, and there was overwhelming response. Myself, Dr. Ashwath from Coimbatore, and Dr. Tangavelu from Chennai, and Dr. Levin, Sanjay Levin from St. John's Day, we all came and conducted a workshop, and it was very well received at that time. Antibiotics, no doubt, it's a unique class of medicines, and much progress has evolved over a period of time because of the presence of antibiotics. Death rate has come down. It often saves lives. We know that it can also kill. That's what's very important. And we have to know the optimum route, optimum level, optimum dosage. Then only it will save the patient. Otherwise, it can be disastrous. And based on its the pharmacokinetic, pharmacodynamic characteristic, which you must know something about it. And then for the right duration and also right route and compliance is to be ensured. If all these things are taken care of, then of course it can save lives. So bacteria otherwise will fight back, and if we give suboptimal dose for short duration and not by appropriate route, then we are going to have disaster like development of resistance, and we'll have nothing. And this is the history of discovery of antibiotics. You can find out that salvarsan was arsenic compound was found initially for syphilis and other things. And now we have come to a period where we are hardly any. See the number of antibiotics have been there in 60s. And then it are only 1980, only 3 antibiotics have been added. And 2000, only 3 more. Okay, and hardly any. So there is hardly any new antibiotics coming. Anti-cancer drugs are being, and monoclonal antibodies are being now interested is there, and then it fetches money for the companies. They are not no longer interested in finding out antibiotics. So we have to be very careful, and this is very important. Prudent use is very important. So this is the latest WHO figure. So 2000 year deaths, neonatal deaths occur because of antibiotic resistant neonatal sepsis. It's a very alarming number, and naturally we know, we have all seen how many children, because of bacterium annotatum and other organisms which are resistant to all the this thing, no antibiotics available, in spite of everything adequate dosage, they die. Patient's characteristics is very important. A physician who fails to enter the body of a patient with a lamp of knowledge, not bronchoscope or this thing. Of course, it's very important. Otoscope is important. Light of knowledge to see into the ears, to see otitis media. So, see, Sharaka has mentioned long back. A physician who fails to enter the body of a patient with a lamp of knowledge and understanding of the patient can never treat diseases rationally. So, how true it is. Then again, Charaka, doctors or physicians' characteristics. He has already stipulated during that time. One who advocates a test before the time has come, then it will be negative. We know about, blood culture will be positive, urine culture will be positive at a particular period of time in enteric fever, blood culture, then Vidal, all these things. So one who advances the test before the time has come, differs when the time has come, or he has delayed it, then he may not be having correct results, or sends the appropriate specimen. See, he has told about the specimen collection also, and appropriate sampling being sent to the laboratory in appropriate quantity. See, each and everything has been told by Charaka. Will not diagnose a disease even if it is diagnosable by clinical findings. So, how meticulously he has mentioned it earlier. Then, of course, steps in the institution of rational antibiotics. If a patient can be made well by many ways, then choose the least troublesome. We know so many viral fevers, bronchiolitis, etc., without antibiotics and without this thing. They're all infections only, but they become all right. So it's not necessary that we have to rush in otitis media as well as sinusitis with antibiotics, etc. Now coming to our William Osler, the great clinician, 1920, to prevent disease, to relieve suffering, and to heal the sick. These are work. This all of you know. The desire to ingest medicine is one of the principal features which distinguish man from the animals. So people go for medicines, though they don't need it. Okay, so they are thinking so many vitamin tablets they take unnecessarily. Now, what is the steps to consider? Seek to find, as Thiruvalluvar has said, define the problem, diagnose child's clinical problem. It's an infection or non-infectious conditions. Very important. It can be anything else. Specify the therapeutic objective. If it is a meningitis, we have to use bactericidal drug. Okay, adequate levels to be maintained at appropriate time. Intravenously, it has to be given for a certain period of time before we can think of switch over to other alternatives. So therapeutic objective should be labeled what we are thinking of doing to that particular organism and how long it has to be given. Verify the suitability of the antibiotic P drug. P drug means its effectivity and also its cost, safety profile, etc. Personal drug should be selected and you must have a list of it for each and every condition. And write a prescription legible and unambiguous with proper handwriting, and inform and instruct the patient correctly how to give, how often to give, before food or after food, etc. Monitor response, very important. So you have to monitor the response within 24 hours. You can ask them nowadays. You can ask the child, if the child you haven't started antibiotic, you are still thinking of a possible bacterial infection. You can ask them just to show the video clipping and also report to them. It's very important. You should not hesitate to do that in the present context. There are no safe drugs. All drugs have side effects, all of us know. But only doctors can be safe if they are properly trained and they have proper attitude. Criteria for rational choice of antibiotic, we already mentioned. Safe, it must be safe with minimum side effects or minimal adverse side effects. Efficacious to do the problem, to do the job. Affordable, as I mentioned, the cost is very important. Acceptable to the child. In the formulation is also important. You cannot give a bitter medicine and also give to a child. Child will be vomiting. So it's very important formulation. Acceptable to the child, palatable to the child. It must be available at all times. It must shortage must not be there. So you should not start and then you find it is not there. Sustainable. So that you are giving a costly medicine, it must be continued till 10 days treatment or 14 days treatment. Okay. Now, criteria for rational choice of antibiotics, we already mentioned efficacy. I will not go to that. It must be available locally, sustainable. So this is what is important is how to choose. This is efficacy and cost. Cost, efficacy. There are four these things. See, find it must be highly efficacious and low cost. Such medicine should be there in your armamentarium to treat the child as in the hospital, government hospitals. So first choice must be made where they, it does the duty as well as paid less. Okay, that's very important. That's what we want our laborers. We want to have cheap labor, but we want them to be very effective in doing the work. Similarly, now coming to efficacy and safety. Cost we have talked about. So efficacy and safety. So here you find that first choice is maximum safety and greater efficacy. This is the area where we have to select. So we have to put all the antibiotics available and in the proper square so that we can choose accordingly. Prescribing. So it's a very important thing. So it is very important nowadays because the Supreme Court itself has mentioned it must be very legible, and you must put the full name of the by stamp. Clinician's competence and diagnostic skill is very important in prescribing pattern. Basic understanding of the principles of clinical pharmacology. Basic, not extensive, but they must remember the basics. Appreciation of risk and uncertainty and communication. I already mentioned about it, I will not repeat. You see here, CDC Atlanta has released recently Atlanta estimate of unnecessary antibiotic prescriptions. Okay, ear infection, 30% of 23 million prescriptions are not necessary at all. Is unwarranted and irrational. And common cold, 100% of 18 million prescriptions. See the amount of cost and profit the company makes. And bronchitis, 80% of 60 million. 50% of 30 million for sore throat and 50% 12 million for sinusitis. Antibiotics have been prescribed when it is viral in nature. Now, one case scenario which has been seen by me, 6-year-old boy with cough, fever, running nose, loss of appetite for 3 days. Poor socioeconomic status, mother employed on passionate grounds on the death of a father because of alcoholism, not because of HIV or anything. Weight 15 kg, no lymph nodes, mild anemia, not sick looking, throat, oral cavity normal, conducted sounds, no other positive finding. Hospital free drugs are available in Jupman. Cotrimoxazole, amoxicillin, paracetamol, penicillin, cough syrup, but the prescription has been written by the doctor. Cephalexin, becadexamine, pediatric 3 cough syrup, syrup L-carine, syrup ciplactin to improve the appetite. Okay, ciplactin is causes insulinopenia by destroying the insulin beta cells of the pancreas, and entamizole, which will cause further loss of appetite because it's so bitter and it can cause gastritis. So this is the prescription which has been given, and see the cost when cheaper medicines and effective medicines are available in the government pharmacy. Now the next child, 8-month-old male child, watery, 4 watery loose motions with no blood, 5 days and 2 episodes of vomiting, mild fever, urination normal. Birth weight 3.5 kg, present weight is 4.6 kg. No signs of dehydration. Was prescribed by local pediatrician and given to stop breastfeeding. That was a common advice those days. Microgel, norfloxacin metronidazole combination, deadly combination, and simethicone suspension, and loperamide, which has killed so many children in Pakistan, Asian countries, by causing paralytic ileus and toxic ileus. So this has been prescribed, and lactonil. He has stopped breastfeeding and has given lactonil because he is thinking of lactose intolerance with 5 days of diarrhea. And see this prescription. Okay, so can any one of you make the what is written there? I cannot make out. So we should not be like this. There are so many medicines being
Dr.
peddled by.
Sailendra, mute yourself, Dr. Sailendra.
So you
Dr.
find
First
that
F4.
medicines are being sold by a person on the roadside. All the herbal medicines. So we should not be like that. So we must know what we are dealing with and what we are prescribing. So improper training, unhealthy attitude towards drugs, patients and parental anxiety should not be the cause. You should try to give reasoning and then try to bring down their anxiety, but not by giving antibiotics. So pressure expectation at every visit. So what is important is whether the demand is real or false. Fear of losing patient and practice. So if you don't write an antibiotic, there is a next door neighbor practicing who will prescribe antibiotic. Immediately they go there. So that fear is always there in the minds of a practicing doctor. Okay. Inappropriate response to non-infective states. So sometimes, we think give an antibiotic, we think it is because of the antibiotic child has become all right. Unrealistic expectations of doctors, parent, and both, and also the pressure from the companies. So antibiotics are seductive. Once you think antibiotic has so much of power, then you start prescribing for everything. Then therapeutic enthusiasm and knee-jerk response on the part of the young doctors who are coming up. Of course, they follow some of the seniors who have been prescribing wrongly. Over energetic treatment, incremental prescribing. So they give too many antibiotics for one single condition. Lack of time for taking history. This is the most important time because overcrowded practice. So they have only hardly 5 minutes or 10 minutes for a patient because they have 50 patients waiting. The pressure of time is very important. They hardly take proper history and they lose the important clue towards the cause and also the type of bacteria or virus, etc. And clinical examination, hardly there is any time. I still remember my younger days. When I was a school boy, he was taken to a doctor. He was not a specialist, but a radiologist, but he is a very popular doctor. And then no, he will ask us to open the mouth and then see, open the mouth, and then immediately he will start writing the medicine, and tetracycline, acromycin will be prescribed for me at that time. If there is a diarrhea, Riofin, that was a chlorophenical drug, was this thing. But I have not developed aplastic anemia, luckily, or other problem, bone problem, deposition in the bone, etc. So lack of time for taking history and performing proper clinical examination and counseling in overcrowded clinics, public hospital and OPDs. False sense of security. They think that by giving antibiotic they will not be going to court. They don't understand. We have seen enough cases where they have given antibiotic like dapsone for leprosy, and also they have given dapsone for some other condition. The child developed Steven Johnson syndrome, and one girl died. And I was asked to give this thing, in GH, and I had to go there to give, certain this thing. They wanted my opinion about it. So it's very important. Rational antibiotic use. Basic thought process before prescribing antimicrobial drug to the illness of the child. Essential questions. Is it infection at all? Most of the times it may not be infection, especially diarrhea. Bacterial, viral, protozoal, or others for you to think of writing a particular medicine. Systemic, it is a particular site or it is a systemic condition. So you have to think very carefully. Or regional, okay, so whether it is involving bone or eardrum, etc. Child status very important. After the drug comes the child status, patient's characteristics, age of the child, and the weight of the child, and also the nutritional status, and his vital signs immediately should be seen. Okay, pulse, respiration, temperature. Nowadays, capillary filling time. At least you must feel the peripheries to see the warmth. And pulse oximetry is there. It must be done if it is necessary, especially during COVID season. Alertness, activity, responsiveness, and pulse assessment ABCDE. Status of nutritional, cardiorespiratory, and circulatory status, renal function, because you may be prescribing a drug which may be further causing damage to the kidney, and hepatic function, because not all of them may be having normal hepatic function, so it's very important, and neurological status of the child. And most important is immunological status, because if it is a child is having immunodeficiency, we'll miss it. That's why genetic history is important. If the child has had no previous deaths of siblings, so this child may be coming second time, third time for the same condition, pneumonia. It was very important to find out the immunological status as well as the family background, and also travel, and also recent change in activities, sports activities, and even disasters like floods, etc. Floods or rainy season or drought, they may be taking unhealthy water and other food items. So that is disaster management. No, for example, in California now so much of fire is going on. So it's very important. All these things, environmental factors must be analyzed to find out whether there could be a possible infection. Conscious procedural steps and elements of responsible antibiotic use. So I already mentioned about this thing, but what is important, whether we are going to give as a prophylactic because there is a contact in the house, for example, diphtheria, and there are other children, so you have to find out whether the child has to be given prophylactic antibiotics. You know what are the various indications for prophylactic antibiotics. I said I am having mitral valve prolapse, so if I am going to a dental doctor for extraction of my teeth, then naturally I have to consider whether I have to take prophylaxis or not. Similarly, whether any prosthetic condition nowadays, so many people are having prosthetic this thing, materials in the body. So they have to find out whether what type of prophylaxis they have to take for congenital heart disease, etc. Then empirical antibiotic. So when you have suspicion of infection by proper history taking as well as by clinical examination, you think it's possibly a bacterial infection and I don't want to delay treatment, then we have to do immediately start antibiotic appropriate for the particular condition, thinking of the organisms possible. For example, you are saying the throat which is congested, so you have to find out center score, modified center score, and find out what is the scale, and then decide about the antibiotic and the type of the condition. So we have to give appropriate antibiotic. So empirical antibiotic, before that you have to do, of course, it is important that if you have facilities by the side lab with by attached to your clinic, etc. At least peripheral smear, TLC count, neutrophil count should be seen, and if possible, CRP. Nowadays, CRP can be done very easily, immediately, and then you can get the result and decide about starting the treatment. But culture should be taken. Very important, proper technique should be involved in taking the culture. And then definitive and directed, once we know the particular organism and the sensitive pattern, and then we have to attack directly. And knowledge of the medicine is very important. Antibacterial spectrum, antibacterial prevalence, and local sensitivity pattern, resistance, as I mentioned, dosing, amount, interval, how to give, okay, before food or after food, orally or intravenously, etc. And timing is very important. The duration for how long to give, and when to make them, because we have seen so many patients are given continuously for 3 weeks in government hospitals. So they have forgotten to find out that child is getting antibiotic. So sometimes it happens. They say repeat 1, 2, 3, 4, 5, 6. So they don't know what is 5. So the antibiotic sometimes goes unabated. So it's very important you try to see and then stop. In the temperature chart itself, we write. Okay, apart from pulse, BP, etc., we also write what day of antibiotic being given to the child, especially for enteric fever, etc. Conscious procedural steps and elements of responsible antibiotic use. Seventh point, interactions of the drug should be known. If the child is getting 2 or 3 medicines, we should know whether it's going to, for example, you are giving some antacids or some other medicine which you are giving. Okay, so it's very important that we find out whether there is interaction, and we have to see when to give this one and when to give the other one. Toxic profile, adverse drug effects. So you have to, of course, you must have seen in foreign countries they have pamphlets. So whenever they give a drug, they give the pamphlet of the possible side effects about which they need not be unnecessarily worried. And if what dangerous side effect is there, they have to report. Such printed pamphlets are available in the kept in the shelf in the whenever doctor prescribes the drug, he immediately gives, because litigation rate is very high in these countries. Then unambiguous documentation, as I already mentioned, counseling and education of parents, very, very important. And complaints should be looked after. Many times they don't bother. They have forgotten to give the medicine or they don't give adequate dosage. So we have to make sure they comply with the type, days, etc., duration, and frequency. And then, of course, it's our duty to see the outcome of the child. So what is, I already mentioned, antibiotic prophylaxis given preemptively to prevent serious infection in a well-defined at-risk situation. For example, we know when to give to newborns. What are the conditions where you have to give antibiotics, prophylaxis for children? Rupture of membranes, okay, more than 24 hours, and other conditions where the mother is having chicken pox and only just 5 days, 3 days earlier. Then we have to give to the child treatment. Empiric antibiotic therapy started, as I just now mentioned, when you think there are clinical signs and symptoms which point to a possibility of a bacterial infection or a viral infection like chicken pox, then we have to give. Okay, so preemptively we have to give, but we have to take all the measures to collect material to find out the results. And third reason is directed definitive antibiotic therapy, I already mentioned. Okay. Prophylactic antibiotic, three basic principles, as I already mentioned, well defined at high risk situation. As I mentioned, mitral valve prolapse patient going for a doctor, or a congenital heart disease patient going for dental extraction or prosthetic. So all high risk situations, I will not go into details. Knowledge about the likely organism sensitive susceptibility, and the third important recommended prophylactic antibiotic to be administered. So it's very important this thing, what prophylactic antibiotic is given in a particular situation. Then rational basic thought process before prescribing. Patient characteristic I already mentioned, I will not repeat it. Drug allergy is very important. Okay. I already stressed about the immunological status of the patient. And family, workplace, and contacts I already mentioned. If they have recently traveled, we have seen when I was studying in undergraduate, student went to states from India to after passing ECMG. His typhoid was not diagnosed at all. Finally, they did bone marrow to find out typhoid after so much of treatment. And similarly, we have seen a child coming from America where DS population is very high from Connecticut. The child had fever and also knee joint arthritis. It turned out to be Lyme's disease. So it's very important recent travels and taking bath in swimming pool. So leptospirosis you have to consider or well water. So it's very important. These important things you have to find out. So what are the things which you have to seek? Travel history for empirical antibiotic choice, recreational activities, exposure to IV drug use, then disease severity, urgency of treatment, reliability of lab results, very important. Then host, I already mentioned, I will not mention. Okay, microbe, the source site, depending upon the site, pyogenic meningitis, what we have to give for osteomyelitis, how long you have to give intravenous antibiotics, everything has been documented and you all know about it. Then severity of the condition, susceptibility of the organism, and then community acquired, hospital acquired. So it has very important repercussions and intra or extracellular. Okay, so it's very important. The organism is residing intracellularly, extracellularly, because it's very important to know that otherwise, you may give an antibiotic which doesn't reach sufficient amount intracellular area. Then polymicrobial, there may be more than one microbes. Sometimes nowadays you see very commonly in ICU setup both bacteria and fungus living together. Okay, in the blood, candida infection so common. Efficacy of drugs I already mentioned, bacteriostatic or cidal concentration of time dependent. All of you have heard of so many talks recently about it. Cost and site penetration is very important. Just now I mentioned, and drug synergy. So action. So so many combination drugs are used, which are totally useless, and you must avoid that because it can cause more side effects than what usually occurs with one drug. So this is a summary of principles of antibiotic. Smart it, do it right. Okay, what you have to do, right diagnosis you make. These are all things to make. Right antimicrobial drug, right time avoiding delay, right formulation, right dose, right intervals, route already mentioned. Then focus. Start antibiotics only in the presence of evidence of reasonable definitive suspicion of a microbial infection. Take history of allergies, choose correct drug, initiate promptly. It must be there displayed actually in all the nursing homes and all the this thing, so that he is reminded all the time. Initiate promptly within 1 hour if it is a life-threatening infection. Antibiotics should be given accordingly. Follow pediatric antibiotic guidelines which are available locally, and write documentation I already mentioned with signature and date and time. Factors that influence rational drug and dosage selection. Primary, infection to be treated. That is the primary thing. And then secondary, other conditions that may influence the balance between benefits and harms. Prognosis influences optimum duration of benefits and harms. So so it's very important, optimum duration, benefits and harms, and that depends. No, then drug factors, pharmacokinetics I already mentioned. Frequency of dosing will influence adherence. Bioavailability, if consistent, makes drug response more predictable. Tissue distribution may induce adverse drug effects at non-targeted sites. Routes of metabolism excretion increased anticipation, variable response, drug interaction, greater safety, less frequent. So pharmacodynamics, target specificity, influences likelihood of adverse effects, dose response characteristics. All these things are available in any textbook, so I will not waste your time. Factors that influence rational drug and dosage selection, therapeutic efficacy, I already mentioned. Efficacy and morbidity, mortality, as well as hospitalization days. So whatever causes quick recovery should give. Impact on disease progression and prolongation of life in older individuals. Safety, frequency of adverse effects, ad- idiosyncratic allergic reactions, ease with which adverse effects can be predicted, monitored, and prevented. Then cost, availability, I already mentioned. Patient factors, all the health beliefs and attitude to risk, history of previous adverse drug reactions, very important. So history of drug reactions for previously, it must be documented. Vulnerability to adverse effects, organ damage, reduced physiological reserve, current drug therapy including interacting drugs, likely adherence to therapy and follow-up monitoring. Prescriber factors, okay. So follow-up is very important and depend on resources. Basic thought process before prescribing, I already mentioned, okay. This is repetitions. This is also use empirical therapy first, narrow the spectrum. It's very important that we take a narrow spectrum within 1 hour of assessment if it's a life threatening condition. Then two sets of cultures, not from a line before you start. So you must start line after taking blood culture, okay, not after putting the line. The antibiotic sampling timing with fever is not mandatory. Previously, it was mentioned that sampling timing with height of temperature is important. Then only you will find the bacteria. So it's no longer necessary. Use a proper dose first up. So proper dosing is very important. Avoid underdosing. Sorry, the S is missing. Use monotherapy when and wherever possible to reduce cost and toxicity and adverse effects. A shorter course is probably as good as a standard 2 week regimen. Nowadays, many of the treatment has been cut down to a few days. So this is available in this thing, for Scotland. So it gives all the empirical antibiotics to be given. So right from CNS infections, skin infections, throat infections, and the respiratory, lower respiratory infections, etc. Similar guidelines should be available, and it's made in many hospitals. Even Mahatma Gandhi in pediatrics department, they have made similar diary. And Kanchi Kamakoti Hospital recently they have brought out a book where they have mentioned all the guidelines for all the infections. Common errors of antibiotic use. Okay. Antibiotics given before cultures are taken, poor quality blood culture collection, ridiculously long course of antibiotics. Many times it is given unnecessarily for a longer period of time. Widely erratic changes of antibiotics, constantly every 3 days. Even I was accused once, one of my big postgraduate. So when I said I am not going to change the antibiotic because you want me to give another antibiotic for a non-typhoidal salmonella case having diarrhea, I said we haven't given enough time. So we haven't even given 24 hours before we think of changing. Just because a newer antibiotic can give a guarantee that if I start this medicine, and the same person went to UK, and after his training in neonatology he came back. So he remembered that particular event. Sir, I'm sorry that I made a remark, okay, that you didn't start, and I said you could kill the child. And later he said, we cannot get any newer antibiotic without the permission of higher authorities. So that is the type of surveillance they have and control they have in the use of newer antibiotics. Inadequate doses, poor choice of, it's very important that there is nothing wrong in checking the dose before prescribing. It's not possible to remember all the doses just because this thing. So in front of patients, you not feel bad to check the dose, but you have to mention the correct dose. Poor choice of, once I have seen a patient given, azithromycin. They have given almost 10 times the dose because they haven't read it properly. Failure to predict toxicity or account for interactions. Inappropriate polypharmacy already mentioned. How much more time I'm having? Dr. Anantakeshavan, how much more time? So
You can take your time, sir.
what is to be told to the parents? Very important. Okay, please, we have to spend time with parents so that they have confidence in you, especially when you don't prescribe antibiotic at the first visit itself. Diagnosis, why I am not giving antibiotic, what is the cause of infection. They are ready to listen. Basic information regarding antibiotics prescribed, why, what purpose it serves. Okay, I am not giving antibiotic just because I want to give, because there is a specific reason I am giving this, and how long you have to give, benefits when given and dangers if not given. Of course, we need not frighten them unnecessarily. It depends upon how much level of knowledge they have, and accordingly we must tighter the amount of information we give. Otherwise, it can be counterproductive. How to give to child, this is very important. Just now I mentioned about azithromycin, 10 times the dose was given for a child. Okay. frequency. Similarly, they were given a vomiting, Lorgatil. Those days, Lorgatil was given to stop, and child had oculogyric crisis, and they said it's convulsions, and the child was treated as meningitis because child had fever. Okay, so it's very important that we tell the side effects. How to know child responds or does not respond to the drug. So symptoms of improvement also must be told, and you must also tell danger signs. If you are not giving antibiotics and you think it's viral fever, so if such things occur in your child, please report to me immediately, either by phone or by telephone, or come personally. I don't mind seeing the child again. So it's very important we tell them and assure them especially when you don't give the antibiotic medicines. Side effects, you need not give every side effect to frighten them, but you have to tell, okay, these are the possible side effects for which we need not discontinue the drug, and to consult by mobile in case of doubt or worry. So, what is when you are not giving antibiotics? It is our duty to say, especially in dengue, what we tell them, when you have to bring the child for admission. Every child cannot be admitted in the hospital because beds are not available. Similarly, in COVID season also, all children COVID positive need not be admitted. Okay, so we tell what red flag signs must make you bring the child back for re-examination and admission. Consult when new symptom signs develop. Report immediately if you feel something is not all right. Nowadays, cell phone, mobile phones are there. Video, they can take that and then send to them, and then they can consult, as happens in COVID time when you don't want to take risks. Then this is the most important thing. Principles of antibiotic prescribing stewardship. Okay, smart. I already shown this is the repetition. Okay, so kindly keep it in all your hospital premises so that this will remain. Okay, so I will not repeat, but this I am again showing the same slide because this is the essence of my talk. So what is important? Limit prophylactic use to appropriate situations. So kindly understand that you must have a list of conditions where immediately you decide whether the child needs prophylactic antibiotics or not, just like a newborn. Consider non-infective cause of inflammation. Give a strong emphasis to infection control policies to avoid resistance. I am quoting this man. He is a neighbor to me, Dindivanam, about 42 kilometers. Recently, he gave a talk in Central IAP, and he is now, he was my admirer at one time. So now I am his admirer. So he has used, and he writes and also monitors what antibiotics is giving. He is making note of all the conditions he sees, and he knows how much percentage of children he has given antibiotics, etc. Such meticulous, and he also immediately sees the TLC, CBC, everything, and the peripheral smear in his the laboratory is there adjacent room, but he can see in the microscope in his table the scanning of the peripheral smear, and he does CRP immediately. So nationally known, now he is a very popular speaker, a very wanted speaker. So he has done DCH. I was his examiner in Bangalore Medical College. Subsequently, he has been as a practitioner. He had done appeared MRCP, and he has passed it. So everything by self help only, and he has been listening to all the talks of all the stalwarts and collects all the PowerPoint slides they have, and then by that he has learned, and then he has been practicing rational medicine. I am a great admirer of him. Cost-effective, appropriate treatment of infections with prudent, rational selection and use of diagnostics and antibiotic drugs. Okay, so he recently gave, and I am quoting that particular. I have taken permission from him. Okay, this he has already mentioned. See here, principles of rational antibiotic. Is this infection very likely? Is it bacterial infection? He has done WCC, that is white cell count, CRP high. Then what is the site of infection? Chest X-ray same. When this thing okay, and then urine he has taken central line. Post stage immunocompetency. What are the likely organism gram-negative bacilli? Finally, community acquired, hospital acquired. What is the likely source? Okay, here finally logistics, availability, cost, side effects, piptas rather than meropenem. This is a slide he showed, and I took his permission, and he has granted me permission. And he has used only these many 4 antibiotics for most of the patients. 90% of the patients are given for infections, common infections, only 4 antibiotics. So see his method of rational high probability of acute by empirical antibiotic therapy by Palani Raman. Okay, obtaining careful history, performing non-hurried thorough clinical examination using otoscope, immediately getting CBC, differential peripheral CRP. See, bacterial sinusitis, otitis media, first drug he used amoxicillin, rarely amoxiclav, maybe 15%, and the organism he knows what are the common organisms which causes. Then acute tonsilopharyngitis, again amoxicillin macrolides is the alternative, group A beta streptococcus, and he is the center called modified center scale. Okay, then diphtheria suspected. Nowadays, lot of cases are occurring. Crystalline penicillin IV and then serum, antidiphtheritic serum, and then hospitalization. And community acquired pneumonia, amoxicillin always as a single drug, rarely amoxicillin clav, and pneumococci, pneumococci, they are taken care of. Okay, then pertussis chlamydia nowadays occurring. So azithromycin is the first choice, and second choice amoxiclav. And acute dysentery, cefixime, ceftriaxone, as the child is very toxic, and then quinolones alternatively for older children. Then Shigella species, these are the organisms. Enteric fever, he uses cefixime. Very sick, toxic, ceftriaxone. Alternative, the child doesn't respond, azithromycin. Strep typhus, as all of us know, doxycycline is the preferred, and then azithromycin may be given. Skin and soft tissue, his first choice is cefadroxil, second choice is cephalexin. Acute lymphadenitis, he uses again cephalexin and streptococcus. So this is the usual thing, and I told I am going to show to everybody. Okay, empirical antibiotic therapy as practiced in 90% of the patients he sees, and more than 4 drugs he has not used. This I already shown. This must be there for every hospital. Their policies for prophylactic and empirical therapy. Okay, this is commitments in ICU setup. Prophylactic preemptive antibiotic therapy, early antibiotic treatment in acutely ill or deteriorating patients, and what is the optimal antibiotic use and responsible antibiotic use. There is a tabular column, and of course these slides can be PPT can be given to all the participants, and this thing, so it's available also in the. And this is the final this thing, important message: education. Okay, by experts, resources, guidelines, evidence-based guidelines are available. Patient and physician. Then resistant surveillance. So ethics already mentioned. So resistance, future effectiveness, waste disposal is very important to prevent this thing. And patient outcome has to be seen. And infection control and vaccination is very important to prevent infections. And microbiological diagnostics. So access and availability, indication, okay. Regimen, antibacterial activity, spectrum, dosing, I already mentioned, duration, routine, timing, interactions, and unintended consequences, and patient complaints. So this summarizes rational and reasonable, logical antibiotic use. So writing is on the wall for all of us to see and feel and act rationally and responsibly. You can see here. See the penicillin discovery, antibiotic resistant plasmid in 1960, and the lean years and troublesome fluoroquine resistance. So now hardly we have any antibiotics. Okay, for controlling infections, and people working in intensive care units know the difficulty of treating infections. So it's very important that we try to have the susceptibility sensitivity pattern of the hospital available. Hospital infection committee should be available. See here, by constant educational inputs and training and government control measures, see the change in antibiotic behavioral pattern, outpatient care in 25 European countries. Coordination program and national campaigns. See, hardly they are now using in so many countries. It has come down drastically between 1997 2003. We must see that happening here with this type of enthusiasm among us. To save ourselves from COVID, we are changing our behavior by wearing masks and protective gloves. Okay, many of us, of course, some of them they don't follow the rules. To save our grandchildren, high time to pay heed. Otherwise, we don't have antibiotics to treat them. So, what is patient centered optimal antibiotic use and society oriented responsible antibiotic use? This is the basic principle of antibiotic stewardship, and such steps and measures to face crisis of alarming rise of resistance to antibiotics. Kollam has done, Kollam Pedican has done that. They have done one workshop on antibiotic prescribing. Similarly, I think in every conference and every meeting there must be a workshop on antibiotic prescribing, like breastfeeding and infant young child feeding is coming. You must try to do that. So regular monitoring of antibiotic usage and drug usage, as Dr. Palniraman does in his own clinic, evaluation feedback to prescribers, active involvement of clinicians in the development and dissemination of consensus and evidence-based guidelines in antibiotic use, clinical decision support systems and other aids such as treatment cards and handheld computerized guidelines. Use of infectious disease consultancy services must be available. Improvements the use of diagnostic microbiologic techniques. Today, the Ranu Singhal has talked about it. You must have heard in the morning, in the 9 o'clock to 12:30. She talked about the diagnostic investigative facilities and its pitfalls and this thing how it can be used. Improvements in the use of diagnostic microbiology techniques is very important. Formulary should be available, as I mentioned. Mahatma Gandhi Medical College has, Jipmer has, and many other medical colleges. I have seen Kerala they were having. They had given me a book also, okay, of this thing. And of course, you have Jason, who is the person authority on this thing, drug prescribing, etc. So the most important principle Hutchison says in a clinical methods book, from inability to let well alone, from too much zeal for the new and contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases, from making the cure of the disease more grievous than the endurance of the same. Good Lord deliver us. That is the most important ethical principle we should follow. So concerted, conscious, coordinated educational awareness workshop and campaigns are very important. I will ask South Zone President that workshop should be conducted not only for various other things. Workshop should be conducted for also rational antibiotic use in conferences. I think you must take Dr. Ananthakeshan. I request you take adequate steps to do this in future conferences. Like breastfeeding and infant young child feeding, they have a conference. Developmental pediatrics, they have workshop. So I think we should have this also. This is very important for the future generation of our children. So antibiotic efficacy conserve. We have to conserve for coming generations. Final take home message: stop, think, proceed before prescribing antibiotic for treating anyone. Non adherence to apply and practice basic cardinal principles, selection, rational use of antibiotics will be facing a far worse, helpless situation we are facing with COVID pandemic. That will be worse than that. The day is not far off when we will need to admit, sorry, there is nothing that I can do to cure your infection. Please go to some other alternative system. Okay, to increasing number of our children's parents. But let me end with a positive note. Okay, so it's not all this gloomy. Still, we have time. Though the scenario is bleak now with regard to rational antibiotic use among medical professionals, we shall endeavor to promote rational use with the hope that there will be light at the end of the tunnel. Sincere thanks for the opportunity provided by Dr. Ananthakeshavan and his team, Narayanan and others. Okay, and also for taking this topic and calling me again once more in this platform to talk about a passionate subject on national antibiotic use. Okay, and then I patient listeners. So you're all patiently listening in spite of French Open and so many other webinars as well as cricket. Okay, IPL. You are listening, and patient former President Professor Pramod Jog, Dinvanam, Dr. Paliraman. Okay, so and other all practitioners who have taken their time out to come and listen to me, and also my friends Girija and her husband Madhavan, and also there are so many Girijas. Okay, Girija of Alapurai. Okay, and also so many other Nair and all the others. Thank you so much for your patient listening. I hope I did justice for inviting me, Dr. Ananthakeshav. Thank you so much.
Please stop screen sharing. Over to
Yeah.
Nana.
Yeah.